Good morning, everyone, and welcome to today's webinar hosted by PYA, 2023 Medicare Physician Fee Schedule Proposed Rule, Part 3. PYA is happy to present today's webinar on this important topic. You will have the opportunity to submit questions to today's presenter by typing a message into the question pane of the control panel. We'll collect these and address them by email after the webinar. All of our webinars are recorded and released with a copy of the slides after the event. With that, I would like to introduce Lori Foley, Consulting Principal at PYA.
Good morning, everyone. Thank you, Laura, for the introduction. Welcome to today's webinar. Today, we will be wrapping up our three-part series on the 2023 Medicare Physician Fee Schedule Proposed Rule. This is episode 32 of our Healthcare Regulatory Roundup, if you are keeping tabs. Today, we're going to spend some time digging into MIPS and the changes that Medicare has in store and has proposed for through the 2023 rulemaking, open for comment period. So we will dive right in. Our agenda today, we're going to just do a very high-level overview of MIPS and MACRA, again, CMS's accountable care strategy and how those come together. And then we will shift into those proposed changes on each of the 4 quadrants of the traditional MIPS program. And then we'll round out by spending some time on the MIPS value pathways, which is the direction that CMS is taking the MIPS program. So as Laura mentioned, my name is Lori Foley. I lead PYA's compliance service line and also the managing principal for the Atlanta office. I've worked with a number of clients related to their adoption of MIPS over the years, and digging into the different areas. It's always been interesting to me how MIPS has caused facilities and practices to think across departments and categories, because it requires operational intervention, it includes quality, it includes technology. So a lot of times prior to MIPS, these were in segmented departments often in a facility, and MIPS has really required some departmental collaboration in order to be successful as the program has evolved. So beginning with an overview, my colleague Marty Ross on May 15th covered CMS's accountable care strategy. If you missed that webinar, it is available on our website. You can go back and catch it on demand. But if you followed CMS's progress over the last couple of years, including through the MIPS program, they've been very open throughout the history of MIPS that their goal is to promote the adoption of accountable care relationships in their quality programs. And so today we're focusing on traditional MIPS. Alternative payment models are a big goal for CMS. And then as we'll talk through our conversation today, you'll see that really they are using MIPS and even MVPs as a tool to drive providers towards this accountable care strategy, really looking to get quality out of the programs, not just activity out of the programs. With regards to speculation or maybe even wishful thinking on the part of some, perhaps on the call, that MIPS will be sunset, CMS notes that they will continue making long-term improvements, that they're continuing to evolve the MIPS policies, and with the implementation of the MVPs in 2023, that they remain committed to their program goals. Again, their goals to further refine the MIPS program, but also in its commitment to drive providers towards an accountable care solution that ultimately not only drives quality, but also drives the adoption of risk on behalf of the providers. So if we look at the foundation of MIPS, it originated with the Medicare Access and CHIP Reauthorization Act of 2015, MACRA for short. We're not going to spend much time going into the basics, but recall that this replaced the sustainable growth rate, or the SGR approach, to setting Medicare reimbursement. If you've been in healthcare for longer than 7 years, you likely recall that the SGR and rate setting each year was a bit of a roller coaster ride. Every year, providers were preparing for significant cuts to Medicare reimbursement, and by significant, referencing 15, 20, 25% cuts. And then there was a last-minute Hail Mary by Congress where they would pass a reprieve in early January via some legislation that may or may not have related to healthcare at its origin. This roller coaster made it really difficult for providers to plan year to year. And so in response to that, Congress passed MACRA to accomplish several objectives. One was to bring some level of predictability to providers. And second, to really, again, further that transition from volume to value. You see here the four quadrants of MIPS, which foundationally is a fee-for-service payment adjustment based on a composite performance score. The quadrants have not, the names of the quadrants have changed over the years, but really the quadrants themselves continue to circulate around quality, cost, promoting interoperability, and I still always add formerly known as meaningful use, because foundationally that was one of the early programs and it's locked in a lot of individuals' minds, and then improvement activities. For providers that qualify and participate in an advanced alternative payment model and they achieve a qualifying APM participant status or a QP status, they are excluded from the MIPS reporting requirements and payment adjustments. They have some alternative ways that they are reimbursed. But again, we're going to focus today on traditional MIPS. So looking at how those four quadrants come together, the weight again has shifted over the years, but beginning with 2022 performance year, so our current performance year, the weights shifted per statute such that cost and quality were equal to one another. So as you see here, cost is 30% and quality is 30%. For 2022 performance year, that carries forward into 2023. Promoting interoperability is 25% and the improvement activities at 15%. Those two have stayed pretty stagnant after the very beginning, but cost and quality shifted. It used to be much higher for quality and now it has equalized so that cost is as equal of a component. So let's dig into some of the proposed changes for 2023. So when many think of MIPS, I would say that quality is probably the first component that comes to mind. Over the years, the weight of quality has dropped significantly as cost has increased. Unfortunately, quality often consumes the bulk of an entity's planning and resources, despite that decrease in its weighting. Again, one of the reasons is that impacts the clinical, how we perform services, operations, how we process patients, register patients, gather data, and then information technology to understand and measure, determine the processes and the operational flow, and of course, gather that data to support reporting. For 2023, the data completeness will be 70%. That was actually finalized in the 2022 MPFS. This year, CMS is proposing to increase data completeness to 75% for the 2024 and the 2025 performance years. So one thing that they have shifted to doing is giving us some clear indication a year or two ahead of their kind of directionally where they're going in regards to data completeness. There was some speculation and some proposals in the 2022 rule to increase data completeness to 80%. That has not matriculated out into the final rule, and you can see here they've kind of backed off on that. There is no reference right now to the 80%, but they are looking to lock 2024 and 2025 in at 75%. Recall that quality is a 12-month measure, meaning an entity needs to collect data for a 12-month period for 75% of all eligible patients. So not just their Medicare patients, it would be all payer, all patients in that data completion. As proposed, there will be 194 measures for 2023. That includes 9 additions, 15 removals, and 2 partial removals. Note that there are substantive changes in that CMS's terminology to 75 measures, meaning entities must review their historical measures for any changes that affect how they evaluate the measure, perform the measure, capture the measure for that go-forward reporting. I just wanted to highlight here just some of the new measures because you can see there's some expansion and from a dermatology perspective. We'll talk a little bit about social drivers of health. Those are kind of being interspersed in a couple of the categories that we're talking about today. Kidney health, immune-related diarrhea and colitis, and biomarker testing, and then adult immunization status. That one is relevant as we turn to some of those that are being removed. Just let me go back. So measures proposed for removal. I again we won't walk through all of these, but I did want to highlight them because I think there are in the clients that I've worked with, a number of these are just what I call catch-all measures, where entities were able to use a variety of sources to close the loop and facilitate reporting. Two examples are biopsy follow-up and 439, measure 439, age-appropriate screening for colonoscopies. Also note that measures 110 and 111, which are common primary care measures used by primary care physicians, PCPs, and specialists alike, are proposed to come out of the inventory unless they are in an MVP that you might be choosing to pursue. So those are common measures that a lot of people use, that a lot of EMRs support data collection, so that would be something to look at and evaluate, particularly if you are proceeding with comment submittal. One of the key things I should have mentioned at the beginning that CMS identified is they really are just doing some tweaks to the traditional MIPS. They are really focusing their efforts on the MVPs. So where in the past we might have had a couple of slides for each quadrant on changes, they really were trying to keep the changes to traditional MIPS minimal, and then really focusing efforts to that MVP. So as you see, there was not a lot of significant changes on the quality side. Similar here on the cost. The cost improvement scoring began in 2022. So prior to 2022, CMS just reported cost as a static component for each year. Beginning in this performance year, they are evaluating how a provider changes, how they improve in their cost scoring, and allowing certain points for that. So in the 2023 rule, the current proposed rule, they are proposing to establish a maximum cost improvement score of 1 percentage point out of 100 percentage points, starting with the 22 performance period. So proposing in the 2023 to take care of something in 2022, meaning in scoring for the 2022 performance year, they're proposing that this point will become available. The reason they're doing that is they realize they have to adhere to some statutory requirements that require them to account for improvement in the assessment of performance under this category. So really, they're just trying to go back and tie down a miss, if you will, on the statutory requirement, making sure that they are in compliance. Turning to the improvement activities, there are currently in the 2022 performance year 106 improvement activities in the 8 categories that you see here. For 2023, CMS is proposing to add 4 additional improvement activities, including those that support EHR tagging, ensuring access to care for certain patient populations, and interesting to me, promoting COVID-19 vaccine achievement for practice staff. Though this is only granted a medium weight. The others that we identified were the security tagging is medium weight, the access to care both have high weighting. All 4 of these new activities that are being proposed relate to CMS's 6 health equity priorities for reducing disparities in health. So they are, from an organization-wide perspective, committed to improving or decreasing the disparities in health. And so you will see some of the changes in MIPS to continue to further that entity-wide initiative by CMS. CMS is also proposing modifications to 5 improvement activities, and they are removing 6. Related to promoting interoperability, they are proposing this year, there always seem to be changes, and this year's no exception. CMS has historically granted reweighting for certain providers under the premise that they are unable to control the way that EMRs are deployed, adopted, and utilized within their environment. However, to that end, CMS is proposing to continue automatic reweighting for certain provider types, including those you see on the right side of this slide. So social workers, therapists, physical, occupational, speech language therapists, audiologists, psychologists, dietitians, and then also providers in certain settings that practice exclusively in certain settings, including ambulatory surgery centers or ASCs, hospital-based facilities, non-patient facing providers, and then small practices. New this year, though, is the proposed elimination of automatic reweighting for nurse practitioners, physician assistants, certified nurse anesthetists, and clinical nurse specialist. In reading the dialogue, CMS has analyzed reporting for these types of providers and found that a relatively low number of NPs, PAs, CNRAs, and CNSs have submitted individually. And so CMS is speculating that they are actually disincentivizing adoption and use of CERT, so approved technologies, through its reweighting policy for these providers. So they have specifically requested comments on this proposal and specifically requested insight into potential barriers to CERT adoption and implementation from these types of providers. So if this is something that will impact your providers, you do have they have specifically requested comment on this discontinuance of the reweighting and asking for specific feedback as to the why, not just what it means from an operational perspective. For those for whom reweighting continues to apply, it is most often reweighted to quality, but not always. So if your providers are subject to that reweighting, the QPP narrative does outline the various scenarios so you can follow along to understand where this weight shifts to, the 25% shifts to, so you know where you need to redirect that particular focus. Some additional changes that are included in the promoting interoperability category for this year include allowing the reporting at the APM level, so the alternative payment model entity level, in addition to the group and the individual level. So again, just related to this quadrant, the PI quadrant, there are changes to the public health and clinical data exchange objective that require reporting of the level of engagement. So specifically, CMS is proposing to consolidate the current engagement options from 3 levels to 2 levels of active engagement, and then also requiring the reporting of active engagement for the measures under the objective. So changing some of how that information gets submitted when the reporting occurs. Currently, queries to the Prescription Drug Monitoring Program, the PDMPS, or the PDMP, is optional and worth 10 bonus points. The Medicare Physician Fee Schedule is proposing to make these queries mandatory and for the same number of points. So rather than having 10 bonus points, it's proposed to be a mandatory requirement at 10 points. And then also expanding it to include Schedule 3 and 4 drugs in addition to the current opioid Schedule 2 drugs. Finally, CMS is also proposing a third option for health information exchange, adding a category associated with the Trusted Exchange Framework and Common Agreement, or the TEFCA. Specifically, CMS is hoping to incentivize eligible clinicians to exchange information by connecting directly or indirectly with a qualified health information network. Again, CMS has been clear over the years as this has matured of their goal and desire for connectivity. We know that they have yet to fully define and mandate exactly what that looks like. So I think these are some workarounds as they try to find options for providers to connect and share information in a consistent way, absent just putting it out there as to exactly what that looks like in full definition. So this table shows just some of the scoring shift with the proposed changes for the PI category. As mentioned, you see the adoption of the query of the PDMP is being required, and that shifts the points for some other categories. I know just on this particular slide, it looks like the provider to patient exchange box is gone. You'll see in just a moment, it's on our next slide, but you do see the addition of the participation in TEFCA and it being weighted at 30 points. Again, you can tell by the point allocation that CMS is very interested. They give a high number of points for that health information exchange, the bidirectional exchange, and now the participation in the TEFCA. And this just continues just to show the rest of the scoring. So you see again where the points have realigned based on those particular categories. So there are some changes to the final scoring in 2023. So the performance threshold for 2023 is proposed at 75 points. That's consistent with where it was for this current performance year in 2022. This is reflective of the mean score from the 2017 performance period. You may recall that statutorily, CMS was required to eventually set that performance threshold at the mean score of a prior period. So this is consistent with that 2022 period. There is discussion in the proposed rule regarding which year to use. They note the impact of the public health emergency and the pandemic. So they are evaluating each year what year to use as the base, but statutorily they just have to use the mean from a prior performance period. So right now it looks like 2017 is that measure. Different in 2023, though, is the absence of the exceptional performance threshold. This performance year, so performance year 2022, the one we're currently in, is the last year of the exceptional performance bonus. For 2023, providers who score at less than 18.75 will receive a negative 9% adjustment on their traditional Part B payments. Providers who score between 18.76 and 74.99 will receive an adjustment between negative 9% and a 9% decrease and 0% on a sliding scale basis. If the provider hits that performance threshold spot on at 75%, they'll receive a neutral adjustment, so no increase and no decrease. And those scoring above 75.01 will receive between 0 and a positive 9% adjustment. The actual outcome, you know, is based on preserving budget neutrality. This means that bonus opportunities are funded by penalties assessed. So interestingly, in the analysis, the CMS regulatory impact analysis currently estimates that about 1/3 of eligible clinicians will not meet that 75-point threshold based on historical performance. They note, however, that many providers are close to that 75%. So as anticipated, final outcomes may vary. And then depending on what those final outcomes actually end up being, how many providers hit 75 points, how many providers miss that 75 points, will indicate kind of the pool of funds for those that exceed and score between 75 and 100. The budget neutrality impact is something that was statutorily mandated and will continue through the program. A couple of other collateral changes, kind of a catch-all slide here. On the final scoring, CMS is proposing that facility-based clinicians would be eligible to receive the complex patient bonus, even if they don't submit data for at least one MIPS category. There are also a few changes proposed for public reporting, so physician compare, in an effort to provide patients with more insight into a provider. For instance, they are proposing to report on providers, to require reporting on telehealth services, as well as commonly performed procedures, so that this information can be carried forward into the clinician's profile page to help providers help patients find providers who perform certain procedures or practice a certain way. Again, the goal is to help empower the patient to find, the physicians that meet their criteria. You also may recall that we referenced one earlier, that there were some changes to 2023 MIPS that were actually finalized in 2022. Two of those include the removal of the three-point floor for measures that can be reliably scored, or for measures that don't have a benchmark or don't meet case minimum requirements. For all of these, they would be zero. In the latter, it would be zero, except small practices would continue to receive a 3-point attribution for those measures based on their practice size. So let's shift to MIPS value pathways. I started off at the beginning indicating that CMS is very committed to the implementation of these pathways. And the goal, the high-level goal, is the meaningful comparison among like specialties, conditions, episodes of care, hoping to reduce the reporting burden and improve patient care along the way. And if you think about where, as MIPS has progressed, when it first started, many providers were concerned that there wouldn't be any measures that met their specialty. And before you know it, we created inventories of 300 measures and in quality and 100+ measures and improvement activities. Well, the challenge became that there were so many choices. The probability of like providers choosing like measures decreased. Some of that was ability to perform the measure, gather the data, report on the data. Some of it was driven by the EMRs that practitioners were using and what the EMR supported as far as measure development. So a variety of factors went into that. And CMS really felt like it created too much variability, so there was not an ability to compare providers in a meaningful way to one another. They again note that they're moving to the MVPs to really improve value, reduce burden, inform patient choice, and reduce barriers to participation in alternative payment models. They note that they intend for these MVPs to become the only method to participate in MIPS in future years, although they've not finalized the timing for the sunset of traditional MIPS. In the 2022 proposed rule, they put 2027 out there as a maybe, but they've walked that back this year in the proposed rule and just said that, yep, we're planning to sunset traditional MIPS at some point, but they haven't finalized the timing. So our current timeline for MVPs is beginning in performance year 2023 through 2025. Providers can participate in an MVP as an individual clinician, as a single or a multi-specialty group. They can form subgroups, which we'll talk a little bit more about, and then AP entities for on an MVP for all of the categories. Beginning in 2026, multi-specialty groups are required to form subgroups. And if you think again about what we just talked about, a multi-specialty group has many different specialties by definition. And so being able to compare, one specialty to another, so cardiology to OBGYN within a multi-specialty group becomes less applicable and less valuable to the patient in order to choose services. So CMS is providing a lot of latitude in how an entity divides and forms its subgroups, but it really is driving by 2026 that those multi-specialty groups be broken down in some form into those subgroups for reporting. So beginning 2026, a multi-specialty group cannot report as a single entity. They'll have to have that division as they go through. And then obviously as we continue through these next couple of years, 2023 through 2027 is what they've put out there, they will continue to add specialties to the MVP list because right now it may be a little bit narrow for all specialists. So is 2027 the magic year that traditional MIPS goes away? I don't know. Again, it was proposed in prior rules, it was speculated in prior rules, and they are talking here through 2027. So we'll just have to continue to monitor and see if it gets extended out into future years past 2027. For the specialty determination, CMS was originally planning to use PACOS, so where providers go in and keep their Medicare registration updated. They were looking to use PACOS as the data source of truth for that determination for single and multi-specialty groups. The current proposal is shifting that away from PACOs to using Medicare Part B claims, information that they currently have that clearly drives the types of patients and diagnoses that the providers are treating. If you've gone through enrollments and such with Medicare, sometimes PACOs is, though it's always supposed to be updated, is not always the best source of truth. So I think the claims data is probably a good move. Providers will, as laid out in 2022, so no changes, providers opting to use MVPs in 2023 will register during the performance year between April 1st and November 30th. So between April 1 and November 30, 2023, unless CMS identifies a later date, and if the provider is using, or it's really an or, if the provider is using CAPS for MIPS surveys, that program requires registration by June the 30th. And so there is an advanced date, if you will. The addition of or a later date specified by CMS always opens a window for anticipated delays in the rollout. It makes me wonder if they're preparing for some glitches based on prior rollout of changes. We've all seen deadlines come and go as they are working to get the processes, but they're committing to, it sounds like trying very hard to open that registration on April the 1st. When you register for MVPs, you'll have to have information at your fingertips with really what your plan is. So you will have to select at the time of registration the specific MVP that you intend to report on. You'll have to identify the population health measure that you plan to report on. And then if the MVP includes an outcomes-based administrative claims measure, you'll also identify which one you intend to be scored on. Changes will not be accepted after the November 30th window closes, and you ultimately can't just change your mind afterwards and submit on an MVP that you didn't register for. So you will need to do some analysis. We'll talk at the end of this presentation of some next steps. You'll need to be analyzing the MVPs and how they fit with your organization so that you will be prepared to register as soon as the window opens. CMS spent a great deal of time discussing the use of subgroups as a way for providers within a tax ID number to organize themselves into those meaningful comparative groups. They're encouraged through 2025, as we mentioned, and they're required for multi-specialty groups beginning in 2026. When you actually register for your subgroups, you will have to include a list of the 10, so single 10, and a list of the NPIs, the National Provider Indicators, in that subgroup. You'll also have to identify a plain language name for the subgroup. That will be important for physician compare so that patients can readily identify what the group is comprised of when they are looking at the public reporting. You'll also include a description of those comprising the subgroup, and then they note that a provider can only register for one single subgroup within a single 10. So if you have a provider that performs services under multiple 10s, they may have different groups or subgroups under different 10s, but for one single 10, if you've got a cardiologist, they would have to choose between internal medicine or cardiology, for example, not both. For the subgroup scoring, CMS is also proposing some modifications such that administrative claim measures are proposed to be scored at the 10 level, at the tax ID level, and then applied to all subgroups, and that includes all of the foundational letter, the quality performance, and then the cost performance. There's no score assigned to a subgroup that registers but ultimately does not submit data as a subgroup. So if you followed along in the 2022 proposed fee schedule and the finalized fee schedule, CMS identified and proposed 7 MIPS value pathways for 2023. Those all still carried forward for the proposed 2023 rule. They also added 5 new ones. They did make some revisions to those that were proposed in 2022. Those seem to mostly relate to changes in improvement activities inventories. And then for each, they are proposing to add the ONC direct review attestation requirement, as it was inadvertently left out of the 2022 final rule. So on the left, you see the existing 7 that have kind of been on the radar for the last 12 to 16 months: rheumatology, stroke care, heart disease, chronic disease, emergency medicine, lower extremity joint repair, and anesthesia. The ones that are added for this new year, the 5, are advancing cancer care, optimal care for kidney health, optimal care for patients with episodic neurological conditions, supportive care for neurodegenerative conditions, and then promoting wellness. And you can see they're going deep on some certain specialties, but they are also trying to, I think, the promoting wellness in particular, provide avenues for clinicians who want to be early adopters for whom one of the other topics may not match. The reporting requirements are very similar to what was laid out last year. So each of the MVPs have a quality performance category with 4 quality measures, where the provider chooses 4 quality measures. 1 must be an outcome measure or a high priority measure if an outcome is not available. And it can include an outcome measure that's calculated by CMS through administrative claims if it's available within the MVP. So not all the MVPs have that opportunity. So that will be based on the details of each individual MVP. For the improvement activities performance category, again, the selection of 2 medium-weighted improvement activities, 1 high-weighted improvement activity, or if the entity is a patient-centered medical home, that counts to capture for the entire category, all the points for the entire category. For cost performance, CMS would calculate that exclusively using the cost measures that are included in the MVP, but using administrative claims data. So important to know and understand what those measures are. Nothing for an entity to calculate themselves, because CMS will be doing it based on the filing and processing of claims in the background. There are a couple of changes on the foundational layer, and by that foundational layer, this cuts across all of the MVPs. All MVPs have this same foundational layer. The population health measures category, again, at the time that you register for your MVP, you would select 1 pop health measure. CMS then calculates these measures through the administrative claims processing and then adds that result to the quality score. For the 2023 performance period, this is new. We did not have this information in 2022. The proposed measures are those you see here: the hospital-wide 30-day all-cause unplanned readmission rate for the group, and then clinician and clinician group risk standardization based on those hospital admission rates for patients with multiple chronic conditions. Again, we see those themes regarding chronic care, hospital readmissions, avoiding those hospital readmissions continue to weave themselves throughout all of the components of MIPS and MVPs. For the promoting interoperability performance category, the participants will report on the PI component the same as required under traditional MIPS, unless they qualify for the reweighting that we talked about earlier for those special clinician types, and then those providing care in certain facility types. So some key takeaways as you're evaluating your next move related to MVP implementation and MIPS in general is, CMS continues to seek feedback on ways to better align clinician experiences between MIPS value pathways and APMs, and really to ensure that the MVP reporting serves as a bridge to the APM participation. Again, if they say it once in the rule, in the commentary, they say it 15 times. This is a pathway to APMs. And so there are a number of areas within the rule related to QPP. I know within the rule there's plenty of opportunities to comment, but several requests for information specifically related to the quality payment program, MIPS, MVPs, and APMs. And so those are listed here. If you get an opportunity, if they speak to you in your practice, to go in and look at the specific categories that they are asking for information on, and let your voice be heard. Similarly to the other changes, these are all proposed, so there are opportunities to provide feedback if you see that any of these changes will be materially challenging or detrimental for your clinicians to be successful. Do avail yourself of that opportunity. You've got just a little less than a month to do that. Other takeaways include, evaluating what you are currently doing and how they are funneling towards those MVPs. Query your vendors regarding their ability to support MVP reporting in 2023. Originally in the 2022 rules, they were driving such that vendors had to be able to support the measures and the MVPs that related to the specialties that their technology supported. And so the vendors have been scurrying to try and maintain current reporting requirements, but also address their programming. And so it looks like there may be some reprieves on some of that. So I would start with your particular vendor and the resources that you're doing to see what their plans are, what they're moving towards, and how that aligns with your specialty and your shift on those measures. Same with those quality measures that are potentially being sunset and those that are being added. What does it look like for you as we plan for 2023? Begin evaluating those MVPs. There's a lot of information on each to determine which is applicable to your entity, and conduct some preliminary gap analysis. If you're a multi-specialty group, go ahead and be thinking through how you would subdivide your group into specialties, so that you could identify then which MVPs apply. And it may be at the end of the day, a specific entity is reporting on multiple MVPs, which creates, again, ties back to that prior bullet. What will your technology support? What changes do you need to begin considering in operations and implementation, patient throughput, all of those pieces, because it really gets down to every patient encounter and how you're able to execute on those. Review those proposed changes in the quality measures and the improvement activities to determine if they will be materially impacted, and be preparing for any of those changes that you need to do. We didn't talk much about it. We did mention that, I mentioned that quality is a 12-month reporting period. The rest of them are still 90-day reporting periods. It has to be a contiguous 90-day period. So you have a little bit of time if, for example, your improvement activities are changing materially, as you assess, if you're not using a January 1 as the start of your reporting period. But for quality, you definitely will need to be ready to go as soon as possible. Again, operational processes, data gathering, reporting modifications may need to be modified within your systems, and you're always walking a tightrope between keeping it all working for you to gather your 2022 data while you prepare for 2023. So how you flip the switch and what time periods you do that, you'll have to work collaboratively across your teams with your vendors to work through that. And of course, then watch for the final rule, because we'll see if there are any material changes to these proposed rules, as that will help you refine your planning for 2023 and beyond. So there are a number of resources on the QPP website, on CMS's website, related to these topics in particular. This link will take you to a zip file that then gives you the 4 documents underneath. They have a great changes table if you want to look comparatively, what was in 2022 to see exactly how it looks for 2023. The deeper dives on the MIPS, on the MVPs that they created for 2023, so the 5 new ones. You can also go back to 2022 to get the details on the original. Again, the changes are not, they're very slight changes. You'll see that in the updates on the QPP website. But if you have not bookmarked QPP, you definitely should do that and refer to it often for these changes. As you go through, if you have questions, we too will be keeping our eyes open when those final rules come out. We will be looking to see what gets updated and happens with these. Again, if you were hoping that the rules would be saying, hey, MIPS, we're not really certain what we're doing with it, it's going to go away, that is clearly not the way that CMS is progressing. It looks like it's here to stay. It just will shift to be the MIPS MVPs as we move forward. Just a quick plug for our other regulatory roundups. We've got 2 coming up. We've got on August the 17th, so next Wednesday, the 2023 Hospital OPPS and ASC proposed rule. And then we are setting dates on the rules other rules that will be forthcoming. So the IPPS, inpatient rehab, inpatient psych, and the SNF final rules. So be sure to watch our website and your email for information related to those. Otherwise, we are always available to help as you are evaluating within your entity how to navigate the APMs, the MIPS, all of these quality payments and these new rules and proposed rules that are coming out. So please do reach out if we can assist. And with that, I will give everybody back 15 minutes of their day, and I wish you well.
Thank you. And thanks to our presenter, Lori Foley. If you have any questions, her presentation and contact information will be emailed to you, along with a recording of today's webinar. Also, if PYA can provide assistance with audit, tax, compliance, valuation, or physician services, please call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise, or to subscribe to receive PYA insights. Please remember to stay on the line once the webinar disconnects to complete a short survey. On behalf of PYA, thank you for joining us and have a great rest of your day.